Hello, everybody, and welcome to WADM's webinar on cultural diversity and its impact on COVID-19 crisis management with Dr. Odeda Benin-Goren. Thank you for taking the time to join us today. I'm Sarah Vega, the Program Assistant for WADM. I'd like to cover a couple logistics before we get started here. So during the webinar, feel free to submit questions to the presenter via the question tab in your control panel, and we will share your question during the Q&A session near the end of our time together. And also during the Q&A portion, you may also use the hand raise function on your GoToWebinar control panel to verbally ask your question once you're unmuted. We will make today's material available to you, and we will let you know when the recording and the slide decks are available via an email later today. And that's about all I have. I'd like to give the floor over to Andrew to introduce Dr. Odeda Benin-Goren.
Thank you, Sarah. It's my pleasure to introduce Odeda, who, in addition to the profile I will read to you about her career, is the current chair of the WADM Nursing Special Interest Group. Odeda is a registered nurse certified in emergency nursing. She holds a PhD and has broad experience as a clinical nurse in the fields of internal medicine, public health, and emergency medicine. Odeda was among the pioneers that established the National Emergency Nursing course for nurses to become CEN. As CEN, she specializes in all types of emergencies, including mass casualty incidents in Israel. During the last decade, she specialized in the area of disaster and humanitarian response and works with government ministries and agencies worldwide. In addition to her field work, Odeda is the academic coordinator of the emergency management course at PREPARED, the Emergency Response Center at Benin-Goren University. Odeda is also a United Nations Disaster Assessment and Coordination member under the UN Office for Coordination of Humanitarian Affairs. She is also a consultant for the World Health Organization and the Department of International Cooperation at the Israeli Ministry of Foreign Affairs in the areas of emergency nursing and emergency medicine, trauma, intensive care, disaster preparedness, and risk assessment. So without further ado, I'd like to turn the floor over to Odeda.
Hello and good afternoon from Israel. It is my pleasure being here with you all. I would like to thank you for taking the time of your busy, stressful work during these crazy days and join me. Your work and your contribution are well appreciated. Please keep safe. Take care of you and your dearest. I would like also to use this opportunity to ask you to share your experience during the COVID-19 outbreak, professional as well as private if you wish. With other WADM member, you can send it to my email within at the end of my presentation, or through Andrew and Sarah through the sites. I would like to share with you some of the Israeli experience related to cultural diversity and the impact on COVID-19 crisis management when it's concerned about specific community in Israel. So the Israeli government declared the population to use face masks, practice hygiene, and keep social distance, and keeping home quarantine for those who came from abroad and have been in contact with COVID-19 patient following the first COVID-19 case in Israel. There was the first patient discovered in Israel on the 21st of February among patients that arrived from abroad. And on the 27th of February, the first Israeli COVID-19 patient was discovered. At the beginning of March, the Israeli government restricted most public activity. That includes social activities, public gathering, use of public transportation, closed most of the private sector, reducing the minimum governmental public office and services, and closed schools and universities. At the end of March, with the increased number of COVID-19 patients, the Israeli government declared a state of lockdown, and only essential economic activities and offices remain open. Israel is a multicultural country with several minorities and religions. Of them, 2% are Christian, 20% are Muslim, 78% are Jewish. Among the Jewish, about 8% are ultra-orthodox. Each community got its characteristic, beliefs, and religions rule. All minorities are live all over the country. And in my presentation, I will focus on the exclusive ultra-Orthodox community located in the city called Bnei-Brak. That is a city in the center of the country. The majority of its population are ultra-Orthodox Jew, but not all of them. They regard themselves as the most religiously authentic group of Jewish characterized by a strict tradition as opposed to modern value and practice. The ultra-Orthodox community is composed of groups, each one of these groups leads by the rabbi and follows the Halakha that is often translated as the Jewish law. The collective body of the Jewish religious law derived from written Torah and oral Torah, the Bible. And literal translating might be the way to behave on a daily basis. For example, learning the Torah and gather together in the synagogue is one of the basic daily activity. And it may increase during time of emergencies in a way that it serves as a supporting group or coherence for the community. The city of Bnei Brak has about 200,000 inhabitants. Of them, almost 100,000 are under the age of 18. This might be due to the fact that daily life regulation follows the halakha that favor it in high birth rate. And so, yearly annual population growth rate is about 2.6%, while in the rest of Israel is only 1.9%. This brought the city to become the most crowded city in Israel, with about 27,000 people per square kilometer. Due to its density and the uniqueness of the community, such as large family, that youngest and elderly are living together in small apartments with limited privacy and spaces, increased the COVID-19 outbreak. By choice, the ultra-Orthodox are living in close community and almost disconnected from the rest of the population in Israel. Most of them do not use regular media and social media, but follow the information spread by the community leaders through the local community channel. Their information sources rely on community leaders' message in the synagogue and through their radio station, community newspaper, and what they call pashkavils. This is a broadside of posters that are handed out in the public walls in the Orthodox neighborhood. Furthermore, in the same time that other Israeli citizens are connected to the media by television, radio, smartphone, computers, and are updated about the COVID-19 orders, so-called, most of the ultra-Orthodox are banned from regular media broadcasts and are missing information related to the outbreak. In the same time, continue with their daily behaviors and increase the risk to become sick. Many of the ultra-Orthodox community members gather in the synagogue and the yeshiva, that is the school for the Torah study, as in a normal daily activity. In a way, those places serve as community center and are led by the rabbi. The rabbi message is such as continue mass gathering for praying, especially in time of emergency, were considered more important than keeping social distance or other governmental orders. So the picture that you see right now is an example of a picture that was on a pashkevil that was hanged on the wall, and it say in Hebrew to the community, declaring the praying and keeping the Shabbat is more important than following the order provided by the government to avoid or to keep safe from the corona. So the combination of the absence of reliable information, large families living in a high density apartment, and existence of community activity with almost no option of keeping social distance affected the ability of preventing the virus from spreading in the city and increased the number of COVID patients in Bnei Brak. At the beginning of April, the local media in Israel reported about 730 COVID patients in the city of Bnei Brak that were about 10% of 7,000 cases in Israel, with just before the Passover. This is one of the most important holidays in Israel in the Jewish religious. Furthermore, in the paramount holiday, it has additional religious restriction. Therefore, the days before the holiday itself are characterized by a lot of preparation and preoccupation, including shopping and other activity cause contact between people. During those days, the patient number in Bnei Brak was highest per city population in Israel, and increased the need to have special intervention to break the chain of contagion and to focus on the specific needs and characteristic way of behave in the community. A total lockdown of the city was declared on the 2nd of April. An army officer appointed to manage the COVID-19 crisis in the city. Before instructing the public on the governmental directive, he gathered the rabbis from all groups together, explained the situation and the order referred by the government, and requested them to cooperate as community leaders. The police and the Home Front Command took the responsibility for the public order, needs for urgent supply, including kosher food distribution during the preparation for the holiday. Special attention had to be given to the holiday customs that were more restricted than other days in Israel. Following the next days, the number of COVID patients in the city increased. On the 7th of April, there was about 1,700 patients, and with a week later, you can see that there was more than 2,100 patients. The government offered to use hotels that were converted to quarantine facilities, as some solution to those who identify as minor COVID-19 patients and could not manage or stay at home due to the size of the house or the amount of family member. The ultra-orthodox people refused to be evacuated to those facilities, mostly because of this fact that the community is considered unacceptable to send sick person away from his home and family. The differentiations from other community, mostly modern Orthodox or secular, that use these services and in a way felt relief and even enjoy it because still it was a hotel services. With the requirement of the rabbis as a leader and the use of the traditional communication challenge of the community, the authority approached the people in the way they used to be, in the way the community used, the peshkevil, and then provide the appropriate kosher food as requested to the holiday, and respected the daily activity as the ultra-Orthodox community didn't want to give up. And then decided together with the rabbis how to guide the community to behave with COVID-19 restrictions. So in this picture, for example, you can see that while building the trust among the community, the peshkevil, the same message that they used to put on the wall, now notify to the community member about a patient with COVID-19 at home that he is creating a risk for the community, and this because he refused to evacuate from home to the hotel or to other place while he was living in a very small apartment with large family members. The public follows the government order following this intervention with the rabbi, and they kept social distance while gathering for praying. They didn't give up the prayer, but they changed the pattern of the way they did it, and they kept social distance. They used masks. The rabbi encouraged patients from the community to leave home and to seek care in the quarantine site. Those who refused to be evacuated either remain at home if it was possible due to the condition at home, or receive medical care and nursing monitoring through the health maintenance organization, or were admitted into the community hospital in the city. Ma'aneh Yeshua, this is a Spring of Salvation Medical Center, is a state-of-the-art medical center in the city, provided advanced medical services with about 350 beds and 32 outpatient clinic and institute. In the same time, this is a community Jewish ultra-orthodox hospital. The hospital is strictly managed according to the Jewish religious law. Additionally to the medical, nursing, and administration management, there are rabbis and community leaders involved and assure that the hospital act and respect the religious restriction. During the COVID-19 outbreak, the medical center admitted the first wave, of the COVID-19 outbreak. The medical center admitted 290 COVID-19 patients, which is about 80% of its bed capacity. 256 of them were minor patients. The level of admission of minor patients was quite high due to the specific need of this community in order to take those people from home and don't send them to the hotels. 39 moderate patients, 34 critical patients, among them 6 intubated, and during the period of the first wave, 26 patients passed away due to the COVID-19 outbreak. The lockdown was released in Israel in mid-May. It was in a way too fast, and in part of the country, people were losing the tension, gathering together, giving up social distance, and took off masks. Within 3 weeks, we faced another wave of COVID-19 outbreak with a bit different pattern. There are COVID-19 asymptomatic carrier, young patients, including younger critical patients. But in the same time, Bnei Brak population, in contrary to the other part of the country, continue to keep order. Yet, because Bnei Brak is the most dense city in Israel, COVID-19 patients number in Bnei Brak is still high. The majority of the patients from the community are quarantined at home, while some move to the quarantine sites. This is an outcome of the intervention of the rabbi that convinced the community with advancement of this option. On July, a few days ago, the number of patients admitted into the hospital was about 30, and among them 6 were critical and 4 were intubated. This is just to give you some information about the number of patients in Israel in general and in Bnei Brak. So at the beginning, from the beginning in February, we have about 61,700 patients in Israel, already recovered more than 27,000 patients, passed away about 473. And this week, we have about 34,750 patients. Of them, 317 are critical, 96 of them intubated. If we look at Bnei Brak, which have the second place in the country with the highest number of patients, we have total number of patients about 6,000. Of them recovered more than 3,000, almost 3,500. and active patients these days are 2,600. This week, the COVID-19 patients from Bnei Brak are about 4.2% out of the Israeli citizen. So, what is our lesson learned from this? There is no doubt that the capacity to contain and control the outbreak is dependent on the objective issues such as population density, age and family members, housing, belief, and discipline. It is crucial to identify community leaders and to recruit them to establish community collaboration. By identifying the community leaders and recruiting them to approach the public and be the keynote presenter of the government message, we could increase the community willingness to cooperate and reduce resistance to foreigners, people out of the community who are not familiar with local customs. It is important to use communication channels that are being used by the community in every day in order to explain and present as role model the importance of social distance, using masks, practice hygiene, and quarantine as needed. The establishment of mutual responsibility and target by applying to the public in terms of we together and create public identifications that we are all in the same boat, no matter what kind of cultural diversity we have. And this is an example that following the work that done with the army, with the police, and with the rabbi, the Peshkeville, the message that we're putting on the wall say, if you are reading this note, you are not in the right place. Your place is at home. And this is to encourage the people to keep the lockdown. So the public could identify and cooperate only when they receive clear and accurate information and order. And in the same time, we should fight against fake news. By using reliable communication channel and speakers. It is our responsibility, our as authority or as caregiver, to respond to people's requests by listening and to provide the information and avoid threats. Intimidation might be effective at the beginning of the event, but for a prolonged time, it will increase confused, resistant, and even riot. So, like in any other disaster, there is a need to understand the cultural diversity and as a formulated tire in creating the community trust and cooperation with official authority. Caregivers are required to have cultural sensitivity and competence based on awareness of the existing cultural differences. The establishment of trust, efficient care should be and will involve the community leaders and delegate authority to them. This may help to flatten the curve in the pandemic. That's it.
Thank you, Odeda. That was really, really insightful case study there. I had a quick question. Well, first, just to let everyone in the remote audience know, we are now at the point of the webinar for questions from the audience. So there are two ways to do that. You can send us a message, ask your question and type it out, and I'll read it out loud. Or better yet, you can raise your hand virtually and we can unmute your microphone and you can ask a question directly to Odeda. But I had one question as I was listening to the presentation, and I just wanted to make sure I understood everything correctly. When Israel started relaxing restrictions and reopening the economy in mid-May, I think you mentioned, the population started becoming a bit relaxed with social distancing and not taking the threat of the coronavirus as seriously. which is something that's happening globally, not unique to Israel. But if I'm understanding you correctly, that the Orthodox community actually continued to adhere pretty strictly to the social distancing, mask wearing, and some of the preventative measures that the rest of the population wasn't following as closely. Is my understanding of that correct?
Exactly. Yeah, this is what happened because in the Orthodox community responds in delay in a way, because as long as we didn't activate their rabbis, their leaders, they didn't follow our orders, the secular orders or the governmental orders, because those representative of the government did not represent the community. But in the moment that the rabbis and the community leaders were involved, they were listening to them. And because of the specific situation in this city, that is a very dense city, that the families are living in a very crowded places, the rabbi guided them to keep and continue with social distance and continue with using mask and everything, and they continue to listen to them. So in a way, at this stage of the release of the lockdown, they still follow the order referred by the rabbis and respect it. So in a way, it's better.
We have a question here from the remote audience from Saminda Kamura, and he asked, how did you achieve social distancing, hand washing, and face mask usage? What methods did you use? And he's referring to the Orthodox community because I sent him a follow-up message. He was wondering, I know you had kind of mentioned it before, that normal communication channels didn't work very well in the Orthodox community. Not very many people listen to the news or on social media. Could you just summarize some of the methods used to get that information out?
Yes. Okay. There are two aspects of this. One, yes, in general, the community, the ultra-Orthodox community follows the messages that publish in their own community. In the same times, it's not that all of them are not connected. Some of them do have connection, some of them work out of the community, and they do know what's happened. But if it concerns the whole community as group, they are mostly focused on the information that provided to them by their own communication system, which means the pashkavil, what they call, this is a Yiddish word, the pashkavil is this is message that they put on the wall, because not everyone have television. So when you are walking in the street, you see it. So at the beginning, if you are not involved, the leaders, then the leaders are the one who are responsible to spread all the message on the pashkavil. So as long as the leaders were not involved there, the community didn't get the message. So they did kept normal hygiene like any other people in the country. They wash, they use soaps, they use everything like other people, but they didn't use at the beginning mask. They didn't use alcohol gel in the beginning because they really were not aware for this. But in the moment we identify the need to refer the information through the leaders, they follow all the orders. So now what we used to have now, that every order referred by the government or by the Ministry of Health also given to them by their own leaders. So they follow the same orders now. Is this answer the question?
I think so. So it was, you showed some of the posters. So that's quite common to, I mean, it's sort of in this day and age, not terribly common, but there were posters put around the community with information like flyers, correct?
Yeah. Yes. So this poster mostly putting on the wall of the houses. And you have to take into consideration, like, again, the posters are, it's not only their patent, but in other societies, you see, you have posters, you have social media, you have Facebook, you have Twitter. People are connected to this. The ultra-Orthodox community is not connected to all this social media. even among themselves, they are not using the telephone as a tool for social media. So the major part of this is to provide them the information either by the posters, but also while they are in the synagogue or while they are in the yeshiva, the school for Torah study, because this is one of the major places that they spend the time there. So all information can come to these places and they spread it among the community. And then every family member, most of the time from every family, there are some people who are going to the synagogue or to the yeshiva. So they can refer to the neighbors, they can refer to the family member, and the information refer to them through the posters, through the rabbi, through the radio, the local radio station. And again, in the moment that we activate the community leaders, it's spread all over.
That makes a lot of sense. It's quite interesting. I'm watching this presentation. I was trying to think of how this could be replicated in other parts of the world where you have communities that are somewhat isolated for various different reasons, whether it's religious reasons or even just geography, and how you could communicate with those communities to get the information about prevention of coronavirus. And I think it's very insightful, some of the techniques that were used here as far as involving community leaders and instead of relying on push notifications from a smartphone, for example, using posters and flyers, sort of something that isn't as common these days since we're also digitally connected. I have a question here from Elizabeth, and she was asking about the mortality rate from COVID-19 in the population in the case study today. How is that compared to Israel more broadly? Is it a higher mortality rate among the Orthodox community? And I forget the name of the community.
No, it's not higher than this. You have to remember that the hospital that treated the, let me start it the other way. When we found out that we're going to deal with COVID-19 in Israel, one hospital was evacuated in Israel and dedicated to be hospital for COVID-19 patient. Additionally to this, all other hospitals in Israel organized corona department, organized intensive care department, and what's happened during the first wave of the outbreak, the amount of patients spread almost in all hospitals in Israel. The majority of the patient concentrate either in one big hospital, which is a level 1 trauma center, it's Sheba Hospital, and the other one was really Ma'aneh Yeshua Medical Center because it's located in areas that a lot of people got sick there. But if you compare it to the number of patients in Israel and the number of deaths in Israel, it's not more than other patients, other cases in Israel. The numbers that I gave you in Israel are related to all, in the presentation related to all cases in Israel, all deaths in Israel. So it's not only in Bnei Brak. The 26 people who died in Bnei Brak through all this period are characterized like any other patient in Israel. They were elderly, they had additional disease. There was no young patient who died in this hospital due to the corona. And not like this wave that we have more younger critical patient. The critical patient in the previous wave was most of them were elderly with additional disease. So it was very much reflecting what's happening in the city, in the country, sorry. It was not only in Bnei Brak.
Thank you for that, Odeda. We have not too many more questions. We have several comments, and I thought I would just read them out loud. The first one is from Elise, who actually presented for WADM about 2 weeks ago. In fact, exactly 2 weeks ago. So if some of you are on that webinar, you might recall the presentation about triage and ethics. And she says, thank you, Odeda. I definitely appreciate the peculiarity of this portrait of challenges and how to best attend to culturally unique needs and concerns. We have another comment from Sean Smith, who is a WADM board member and happened to have presented for us not too long ago as well. And Sean says, thank you very much, Odeda. Some very valuable translational lessons applicable to a wide variety of practice environments in my personal experience. For example, Ebola in West Africa and coronavirus in remote regions in Haiti. The commonality of human experience across seemingly very diverse environments is amazing. And
yeah, right.
thank you for that, Sean. And then one other comment here from Christy Perkins. And Christy says, this isn't a question, but I wanted to thank Odeda for this presentation. I work in New York City, and having a large Jewish community ourselves, this information is very helpful in understanding some aspects of their culture and how to best communicate and partner with them in healthcare. So I just thought those were all kind of insightful and just very nice comments. So I thought it was worthwhile sharing those. Oh, we do have one other question that came in. Interestingly, everyone's sending me the questions, so I'll just continue to read them. So I hope people aren't getting tired of listening to my voice. We have a question that came from Carolyn. Carolyn says, we commonly use these approaches in international development and global health capacity building and in disasters, especially through crisis and emergency risk communication professionals. Do you interface with people from these areas to leverage existing relationships and methods?
Yes, we do. Look, some of this community member are mostly let me emphasize something. The majority of the men in this community are using the synagogue, praying and studies the Torah. Some of them doing it as a regular basis and they are not working. Some other are working outside and providing the family. Most of the providers in those families are the women. Additionally of raising the children, they are the ones who work and they are more exposed to the outside world, let's say it like this. And they share it with us. And some of them, many of the nurses that I know, they are ultra-orthodox. So in one hand, they have the professional approach. On the other hand, they have their religious restriction, but they combine together and it shares their experience, their knowledge. And sometimes it's very useful and help in order to approach this community.
Thank you for that, Odeda. We have one other comment here from Montre Smith. And Montre says, thank you so much for this presentation. Your information would be very valuable when I teach the graduate nursing programs at University of Louisville in Kentucky. And that, I think, is about it for the questions. We had a bit of a shy audience today as far as asking questions out loud, but that's just fine.
But we have you, Andrew.
Yes, indeed. Did you have any final comments you wanted to make, Odeda, before we close the webinar for today?
No, just again to thank everyone who joined us, and please stay safe, keep yourself safe, keep your family safe, and hopefully we could share our experience, but we will not gain more experience that we have in this area at least.
Well, great. Thank you, Odeda. I really appreciate you taking the time to share your insight and your knowledge on this. And thank you to everyone for participating in today's webinar. We had a really large remote audience, which is great. And it's always a good indication when the vast majority of the participants in the audience stay on for the entire webinar. So that's great. That indicates a level of interest and engagement. So we really appreciate the support. We don't have any webinars lined up for August at the moment. I think we might actually just be taking the month off, but we intend to get more scheduled beginning in September throughout the remainder of 2020. So we'll keep you notified of any new webinars that we get confirmed and let you know by email. And I'll also be sharing links to the recording of today's webinar and the slide decks, hopefully later today, at the very latest tomorrow sometime. So again, thank you everyone for your support and participation.
Thank you, Andrew. Thank you, Sarah. Take care. Thank you, everyone.
Everybody.
Bye.
Bye-bye.